Thank you to our session sponsor, Ariosa Diagnostic, for making this session possible. Our moderator for this session is Nurse Barb. Nurse Barb joined Women's Physician in 1991. She's known throughout the San Francisco Bay Area, where she appears regularly on ABC TV's View from the Bay as the health expert. Please join me in welcoming Nurse Barb.
Thank you. Well, it's great to be here, and thank you all for getting up so early and attending this session. We're going to talk about a very hot topic in OBGYN. As you know, I'm Nurse Barb Dean. I'm a practicing women's health nurse practitioner. I also do some guest lectures at Stanford. Before I introduce this amazing and phenomenal panel to you, there's just a few things we should talk about. We know that there's been amazing innovation in prenatal care, and everything has pretty much changed in the last couple of years in terms of how we test pregnancies. So we're going to provide you with the most up-to-date information available and allow you to ask questions. We'll also be taking some questions from our online audience. Now, if you're a multitasker and you want to tweet as we're doing this session, you can use the hashtag FP13NY. And I'd like to ask for your patience while I read a disclaimer, because we are streaming live, and we have other folks who may not have the opportunity to interact directly with this panel. So the views that are expressed in this webcast are those of the presenters and do not state an official position of Ariosa Diagnostics, nor should they be attributed to Ariosa Diagnostics Incorporated. No representation of warranty is created through this webcast, and you assume responsibility for relying on any information provided during the course of this webcast. Information presented in this webcast is not intended to be medical advice and should not be considered medical advice, nor is it intended to replace consultation with a qualified physician or other licensed healthcare provider. So, in a nutshell, this morning's session should not be considered a substitute for personalized medical advice from your own licensed healthcare provider. So thank you for bearing with me. And what I'd like to do now is just dive in. I'd like to briefly introduce each one of our panelists. And so sitting to my left is Dr. Genevieve Fairbrother. Dr. Fairbrother is a practicing OBGYN physician from Atlanta. And she's also the chief of medical staff at Northside Hospital in Atlanta. Sitting to the left of Dr. Fairbrother is Dr. Adam Wolfberg. Dr. Adam Wolfberg is a maternal fetal medicine specialist. He's on the faculty at Harvard University, and he's also Associate Director of Medical Affairs at Ariosa Diagnostics. Sitting to the left of Dr. Wolfberg is Jennifer Schmidt. Jennifer Schmidt is a certified genetics counselor, and she's also licensed. Now, not only does she work at Ariosa Diagnostics as a medical science liaison, but she also worked right here in the past at Metropolitan Hospital. So you can find information on any of our speakers and the topic of non-invasive prenatal genetic testing, which is also known as NIPT. You can use the Fertility Planit website, so that's fertilityplanit.com. So now, we're just going to dive in, and I'm going to let Dr. Fairbrother introduce herself, then Dr. Wolfberg and Jennifer. They'll introduce themselves, and we're going to dive in with a presentation. So Dr. Fairbrother.
Thank you. So my name is Genevieve Fairbrother. I'm an obstetrician gynecologist in Atlanta. I've been there for just on 21 years, and I've been at Northside Hospital for the past 17 years, where I'm also the chief of staff. Some people may know, and a lot of people don't know, that Northside Hospital is the largest obstetric hospital in the country. We deliver about 18,000 babies a year. And as such, we're extremely busy, as are all the OBGYNs on staff. And on to you, Adam.
Thanks, Genevieve. So I'm Adam Wolfberg, and I recently joined Ariosa as the Associate Director of Medical Affairs. I also practice maternal fetal medicine at Boston MFM in Boston. Maternal fetal medicine is a specialty within OBGYN that focuses on prenatal diagnosis and also on complex pregnancies. And in my practice, back in 2012, we introduced the Ariosa test Harmony to our patients, and were counseling them about different tests that they could choose, and quickly abandoned the others when all of the patients didn't really understand why they weren't exclusively being offered Harmony. So my experience with the test has grown since then. We've included it in our practice, and then recently I had an opportunity to join Ariosa, which is very exciting for me, so I can help get the word out about the test and educate all of you about how we include this in our practice.
Great.
Jennifer.
And Jennifer?
So as Barb said, my name's Jennifer Schmidt. I'm a licensed certified genetic counselor, and I was actually trained here in New York. I went to Sarah Lawrence College and did my clinical internships right around here, right at NYU across the street, and Columbia Presbyterian. So a lot of training here. I moved back to Los Angeles, which is where I'm from, and I worked for 8 years at Cedars-Sinai Medical Center in LA. It's a large prenatal diagnosis center, and had the opportunity to work with a lot of patients who had undergone fertility treatment. We had a lot of relationships with big fertility centers in LA, and we offered preconception genetic counseling and genetic testing, as well as more post-conception ultrasounds and diagnostic tests like CVS and amnio. So I've met with thousands of patients and talked about genetic testing options, and figured out what's right for individual patients in their pregnancies. And as Adam said, I also now work for Ariosa Diagnostics, and it's been an exciting opportunity. I think this new type of testing, this non-invasive prenatal testing using cell-free DNA, is kind of revolutionizing the way we think about prenatal diagnosis. And when I had the opportunity to come and work for Ariosa, it was very exciting, and getting the word out about this new testing and seeing the rapid adoption has been really exciting, because it's a great new option for patients who are interested in this kind of information in their pregnancy. Yeah.
Well, thanks, Jennifer. So we've heard a lot from our panel, and what I'd like to know is a little bit about this audience. So are there any people here today who are planning a pregnancy, just with a show of hands? Anyone planning to become pregnant? Great. Anyone in here who's already pregnant? How about anyone who works in the field of prenatal care or prenatal testing? Great, great. So we're gonna have a lot of good information for you. We'll do a presentation, and then what we're going to do is have time for Q&A. And so what we'll do now is let's talk with our panelists. We have a presentation here. And what we're going to talk about today is what you need to know about preparing for pregnancy, preparing for prenatal care. What are some of the different options that are invasive testing options, and the newer non-invasive testing options for genetic conditions? And also, what is genetic counseling? I think there's a lot of misconceptions. Some people have a lot of concerns about that. But we want to talk about genetic counseling as it relates to prenatal care. So Dr. Fairbrother, we're going to open it up with you. And I'd really like to know, what are some of your tips for how best to communicate when a woman is pregnant? What's the best way to communicate with physicians and nursing staff about prenatal care and pregnancy?
Well, I think one of the first things is you have your first appointment, and hopefully that's prior to pregnancy, because that's when a lot of the work happens. You visit with your physician, you talk about your health conditions that you may have that could affect pregnancy, high blood pressure, diabetes, thyroid diseases, making sure that you've got the ideal body weight as close as possible as you can, be in the best shape you are in, because pregnancy is a stress test on your body. So that's one of the first parts we do. We also talk about conditions that you may have inherited. So for instance, if you're African American, you may wish to test for sickle cell trait. If you're Ashkenazi Jewish, you would want to do the Jewish panel. There are also vaccines that you should use before pregnancy. I like to make sure that patients are up to date with the usual vaccines, measles, mumps, rubella, they're immune. If they haven't had chickenpox, consider having a varicella vaccine.
So you're saying there's a lot to do before someone ever becomes pregnant.
Right.
That before you head in with a positive pregnancy test, there's a lot of preparation that people may want to take advantage of.
And exactly, and nutritionally, you actually ideally would like to be taking a multivitamin with a folic acid supplement for 3 months prior to conception.
And why is that?
Well, it's thought that by the time you work out that you're pregnant, the neural tube, which is has to close for spina bifida not to occur, has already happened. So taking that folic acid on the front end is actually what is helpful. Once you figure out you're pregnant and then start taking it, it's oftentimes too late.
So to prevent neural tube defects, we say women should be taking a prenatal vitamin with at least 800 micrograms to 1,000 micrograms of folic acid to prevent those neural tube defects.
Correct.
So now a woman is pregnant. So talk to us a little bit about vitamins and prenatal care. You've delivered thousands of babies, so I know you get this question all the time. What are some of the things that people really need to remember about that now that they're pregnant?
Well, you continue to take your multivitamins and you eat healthily, but one of the things I didn't mention prior to pregnancy is also if you haven't done it prior to pregnancy, in the beginning, you would want to check some of your risk factors for things like parvovirus, which is Fifth's disease, the CMV, or toxoplasmosis, people who have cats, things like that.
Mm-hmm.
But then when people come in, you want to talk to them about evaluating their individual risk for that pregnancy. And in my practice, we have been performing the Harmony test for the past 18 months. And so we see our patients typically around 8 weeks, and then we encourage them to come back at 10 weeks for non-invasive prenatal testing.
How do you describe the prenatal test with the Harmony test? So I know there's lots of different prenatal tests. We check women to see if they're anemic. But how do you describe that prenatal test with the Harmony test?
So what I tell my patients is that in your body you have cells every day that are dying, and as they disintegrate, they release DNA that fragments. It comes out of the nucleus. And that happens in every human being's body. A really cool thing happens in pregnant women after 10 weeks. They don't just have those DNA fragments from their cells circulating in their bloodstream, they also have those DNA fragments circulating in their bloodstream that belong to their baby. And this is the basis for how the Harmony test is performed. And it is 99.9% accurate in picking up Down syndrome. So from a simple blood test in the mother, non-invasive, no risk to the pregnancy, you can apportion out the part that came from the baby, the cell-free DNA from the pregnancy, and evaluate the chromosomes. It's fascinating. And those results come back in 9 to 10 days. So by the time a patient is 12 weeks, they already have that information, and it's so accurate.
Wow.
I'm very, very comfortable with using that test.
Yes, so we use that in my practice, and I'd like to talk to Dr. Wolfberg a little bit more about that. So how do you envision incorporating the Harmony test into prenatal care?
The Harmony test can be included in lots of different ways, and every practice and sometimes with patients' input is going to incorporate it in a slightly different way. But this is one way on your slide that is, I think, a really good way of incorporating the test. Like Dr. Fairbrother was saying, at 8 weeks, typically, a patient's seen and an ultrasound is done to confirm the viability of the pregnancy. And it's a good time to sort of counsel patients, like she was saying, about the issues that are coming up in the pregnancy. Then patients can come back at 10 weeks and have their blood drawn. And this is a really convenient time for a few reasons. First of all, patients are sort of newly comfortable that this is a pregnancy that's going along well. Additionally, it's early enough in the pregnancy that it's very unlikely that anyone knows she's pregnant except for her and the people that she's shared that information with. So this test can be sent off, and the results are available a week to 10 days later. Then, at 12 weeks, the patient comes back and has the first sort of diagnostic ultrasound test, which includes the measurement of a space behind the fetal neck called the nuchal translucency. This test has been around for many years and is still an important part of practice. But at that time, hopefully the Harmony results are available, and the patient can be very reassured about the information about some specific genetic abnormalities that the test can essentially rule out. Those are Down syndrome and two other common chromosomal abnormalities with chromosomes 13 and 18. Down syndrome, as you know, is related to chromosome 21. So yes, Barb.
So what I'm hearing you say is that a woman can have a blood test at about 10 weeks of pregnancy. She's just found out that she's pregnant. A blood test that's highly accurate to pick up genetic conditions such as Down syndrome. Now, in the past, we had lots of other tests. We have combined screening, integrated screening. But I just want to clarify, at 10 weeks, a simple blood test, there's no risk to the baby, can determine this information?
That's right. And if you don't mind going to the next slide, the Harmony test, in essence, replaces some tests that we've used for many years in practice. You know, the risk of Down syndrome and other chromosomal abnormalities is related to maternal age, and we have struggled between the relatively low accuracy rate of blood tests that have existed prior to this technology and an invasive test, which we can talk more about, but includes a risk of miscarriage. So the Harmony test, along with the ultrasound, just gives a really good look at whether there's a risk for these chromosomal abnormalities, like you said, as early as 10 weeks.
And so there are different non-invasive tests, and there are invasive tests. So can you describe a little bit more about the differences between invasive testing, which we know as amnio and CVS, and non-invasive testing with the Harmony test?
Absolutely. I think it's first important to point out the difference between the older blood tests, which are not risky because it is just a blood test, and the newer non-invasive prenatal testing that is the same as the Harmony test. The older tests include a measurement of different analytes in the bloodstream. Again, it's a safe test, but it hasn't been particularly accurate. And so the blood test alone in the second trimester of pregnancy only identifies about 85% of these important chromosomal abnormalities. And so it misses a significant number. The other real problem with blood testing is the false positive rate. And I don't want to get too into the weeds here, but what that means in essence is in order for that test to work, it's predicated on 5% of all of those tests being positive. And so 5% of patients are told that they are at high risk for one of these really scary chromosomal abnormalities. And I think that's one of the huge advantages of the non-invasive prenatal test, of the Harmony test, is that that false positive rate gets very close to zero. And so the results are something that we can count on, we have confidence in, they're reliable, and that makes such a difference when we're counseling our patients.
I'd like to just say something. That is one of the points that really drives it home for my patients. When I explain to them that the older tests have 50 out of 1,000 patients are going to come up falsely positive, whereas the Harmony test is going to have 1 in 1,000 come up false positive. When you have that kind of 50-fold discrepancy, and the Harmony test is 99.9% accurate for picking up trisomy 21 or Down syndrome, but with only a 1 in 1,000 false positive rate, to me, that makes it a no-brainer. Mm-hmm. And that really was what was sold me, and we have converted in my practice. We converted over, and it's been about 18 months now. So, you know, that was it. That was just done.
It really makes a huge difference. And what we have tended to do is counsel women that when they had that positive result, it was really challenging because we could tell them that although their test was high risk, it was screen positive, actually the chances were that their fetus was normal. But the only way to find out, the only way to be certain, the only way to sort of provide genuine peace of mind was an invasive test. So that's an amniocentesis or a chorionic villus sampling, and that gets great results. The results are highly accurate, but that invasive test is uncomfortable, and the real problem is that it carries with it a risk of miscarriage. And that's a terrible choice that patients have had to make. Are they going to get great information that they can hang their hat on, and take a risk of miscarriage in this highly desired pregnancy? Or are they not? Are they going to sort of take this highly concerning positive risk score from the blood test and not find out? And I think that that's just been a huge advantage, and I think you've seen this as well in your practice, that with the Harmony test, you can really count on the results. It provides a level of confidence and reliability that we just haven't had before, and it's just been a godsend for our practice and for our patients.
Mm-hmm. And before we move to Jennifer Schmidt, I just want to reinforce something. There are risks to invasive tests. So the accuracy level is over 99%. But can you talk to us a little bit about the risks of invasive tests? Not just the risk of loss, but there's definite emotional trauma that goes to families as they've heard, oh, you have a test result here that's positive. And you spoke about that, but it's not an immediate test. Often people have to wait to get the next test done, and they have to wait for those results. So talk to us a little bit about those risks.
The sequence of events is really traumatic, because in these 5% of patients, and it's really 5% of all of our patients who have that older blood test, they have the blood test drawn, and then several days later they get a phone call saying your test is high risk. And now they have to come in for a counseling session and figure out what they're going to do. How are they going to act on that information or not? And then, like you said, they have to schedule the invasive test. That has to be done, and then there's a period of time between when the test is done and when the results come back. And I've counseled hundreds of women in this particular situation over the years, and done hundreds of these invasive tests. And it's a tough process, and I think it's one that fortunately we're doing less and less of, much to the benefit of our patients.
Haven't you noticed that? I mean, I've noticed in my own practice that the number of invasive tests that I have to do, amniocentesis, has gone down significantly, and the number of people I'm referring for CVS has dropped dramatically too. I mean, 50 out of 1,000, right?
Mm-hmm.
So because when we look at numbers like 5% false positive rate, well, we think, oh, that's not very much, but that 5%, like you said, and like you're reinforcing, that's 50 out of 1,000 women who are being asked to have an invasive test that has a risk of loss. And so what I'd like to do now is let's talk a little bit more about genetic counseling with Jennifer Schmidt. So Jennifer, what I'd like to do is get some background from you about, what is genetic counseling, and who should have it in pregnancy?
Right. Well, genetic counseling is basically just a conversation that you have with someone who knows a lot about genetics and a lot about genetic testing options. Usually it starts off with a family history where we ask a lot of questions about your pregnancy history and other people in the family, and try to identify if there's anything in the family that may pose an increased risk for a pregnancy. And then, we do that risk assessment, discuss that, if there is an increased risk for anything, whether there are testing options available for those things and what those options might be, and help patients to, figure out what their goals are and what they really need to know and what testing options might be right for them. And then, if someone does decide to pursue genetic testing, if there is, a high-risk result on one of these screening tests we've been talking about, very often that genetic counselor will then go over those results, talk about further options, and figure out what to do from there. So it's basically a conversational process and helping patients to make decisions about genetic testing options and what's right for them in their pregnancy. Usually people who are referred for genetic counseling are either people who have a family history of a genetic disease, or people who have already tested positive on a blood test or an ultrasound, and there's this increased risk for a chromosome condition, or sometimes it's just as simple as you're going to be 35 years or older at the time of delivery. But I'm a strong advocate that anybody who has any concern about the genetic health of their fetus should have genetic counseling and have that conversation. And I think that the best time to do it is before pregnancy. There are things that can be tested for, like Dr. Fairbrother mentioned, these carrier screening panels in certain ethnic backgrounds, and other genetic tests that we can take care of ahead of time and do these risk assessments ahead of time, so that hopefully we can put some issues to bed and have one less thing to worry about once that pregnancy is achieved. So I think it can be scary sometimes to have these conversations, and people don't like to think about these possibilities, but knowledge can be empowering, and I think it's important to have these conversations and to do it sooner rather than later. And usually we get to give good news. Most babies are healthy. So.
And I think so many people talk a lot about family history, and there's so many different conditions that you worry about. Tell us a little bit about how family history plays that role with things we might not be able to test for. And I think about people who may have mental illness in a family,
right.
And people who may have autism in a family. Sometimes they're coming to you and asking, can you test me for that prenatally?
Right, and there are a lot of things we can't test for. The human genome is very complex. We have 20,000 some odd genes, and at this point we don't even know what half of them do. There are a lot of things that we can't test for, but there are a lot of things that we can. And I think a lot of times there are things that people don't even realize are out there. And it is important to take the family history and see if there is anything there in the family that can be addressed ahead of time, or whether someone even wants to address those issues and to have that conversation. But then there are things I think that people don't even think about. As you mentioned earlier, ethnic background is also something that we need to consider, that there are things that are just relatively common in the general population. Not everything is inherited, and so there are things we can screen for and sometimes even prevent if we have that foreknowledge.
So the Harmony test is superb at testing for a couple of the most common genetic conditions. Can you tell us what those are?
The first of those is Down syndrome, which I think most people at least have a passing familiarity with. And the second two conditions are trisomy 18 and trisomy 13. And now the test has actually been expanded to test for other chromosomal conditions that involve the X and Y chromosomes. So basically these chromosomal conditions are random occurrences, and no pregnancy is without risk for these conditions. There is this increasing risk as women get older for chromosomal conditions, but it's not based on family history. It's something that everybody should really think about during pregnancy, and some people may be at higher risk than others, but some of these conditions, such as Down syndrome and trisomy 18 and 13, are associated with mental retardation and sometimes shortened lifespan, and can have a really significant effect on the life of that child as well as the life of the whole family. And some of the conditions that we can now test for these that involve the X and Y chromosomes, they tend to be not as severe, but can have issues like learning disabilities, infertility issues for that child when that child grows up and wants to have a family. So things that may not necessarily change how the pregnancy is managed, but can certainly inform how to take care of that child once that child arrives.
So as I listen to this, I think, well, is the Harmony test, the non-invasive test, is this just for someone who's over 35 or 40, or should all women consider having this test?
I think it's an option for all women, and we used to just offer amniocentesis and some of these genetic testing options to women over 35, but actually the majority of babies born with chromosomal conditions are born to women under 35, because like I said, even though the risk is lower, there's more women, I think, in that category. So I think, every woman should consider screening for chromosomal conditions, and as we've already talked about, it's a great option. It's non-invasive, high accuracy, very low false positive rate. So it's really changing the way we're doing things in prenatal diagnosis.
I think it's important to remember that 87% of Down syndrome babies are born to women under the age of 35.
Absolutely.
And that's an important thing to remember, which is why I offer it to all of my patients.
And
right, and sorry.
No, go ahead.
Those women who are at low risk, they may not want to consider doing one of these more invasive tests that has a risk of miscarriage because their risk for chromosome conditions is so low. But if they could do something non-invasive, I think it's a really good option for those women in particular.
So Dr. Wolfberg and Dr. Fairbrother, this brings up a good point. In my practice, for every woman, regardless of her age, we're doing nuchal translucency, the NT ultrasound at their first ultrasound. We're offering them combined screening. We're offering them AFP testing. So we're really offering a lot of non-invasive testing to screen for genetic conditions, aren't we?
Yes.
So we're already doing that. So is NIPT, non-invasive prenatal genetic testing, is this just something that we can also offer to women as another option instead of the more traditional older tests?
Well, that's exactly what I do in my practice. I offer the non-invasive prenatal test. You get the results earlier. It's more accurate. There's lower false positive rate. Why wouldn't I offer that to why should a 24-year-old have a 50 and 1,000 false positive rate, but someone over 35 doesn't get that? So I absolutely offer it to all of my patients.
And Dr. Wolfberg, what do you think about that? Is this something that all women should have the option to do?
I think it's a great option. I really do. And I think that historically we have divided pregnant women into those who were less than 35 and those who were greater than 35, sort of arbitrarily, because we do know the risk of these common chromosomal abnormalities does increase with age, but there isn't some magic dividing line. And to create a set of tests that are available to older women, but not to younger women, is, I think, a little bit arbitrary. I think that we've done it with the best of intentions, in part because the alternative we had for a great result was an invasive test, which was uncomfortable, expensive, and carried that risk of loss that's so devastating. But I think that with the development and availability of these highly accurate, non-invasive tests, that arbitrary line will hopefully disappear.
Yeah, I think historically that line was, you have a certain risk of miscarriage with these invasive tests around 1 in 200, and at 35 it was the time when women passed into that risk category of about 1 in 200. So, weighing those two things, the risk of chromosomal conditions versus the risk of miscarriage, once the risk of chromosome conditions surpassed the risk of miscarriage, that's when we offered these tests. But now I think with these non-invasive tests, like you said, it's an arbitrary cutoff.
The lines have been blurred. Absolutely.
I think you're absolutely right about how that system was created. I must admit to you, I never really liked that system because it's apples and oranges, comparing a risk of an abnormality against a risk of miscarriage. And so now that the technology has improved, I think that to make individualized choices between a patient and her doctor is a great opportunity.
Right. And patients in different positions view those two things very differently. Like you said, it's apples and oranges. Women who have struggled for years to get pregnant, they view that risk of miscarriage very differently. Whereas women who've had a previous history of a genetic condition may be willing to take that risk of miscarriage to find out, even if they know their risk is low, they need to have that information for peace of mind. So it's apples to oranges, and that line is
I agree with you.
kind of
It's true, and I know all of us have interacted with a lot of women who wanted that 99% accuracy rate, and they didn't want false positive rates. And so many of my patients were under 35 and asked for invasive testing because they wanted to be sure about the health of their pregnancy. Now, what we'd like to do is open up this forum for questions. And we're happy to take all of your questions. We're also going to be here after to answer any questions that you may want to ask, and we'll be outside afterwards. But are there any questions from the audience that we can address?
Any testing for autism?
So the question is there any prenatal testing for autism? And I'm going to reference this to Jennifer Schmidt, who's a licensed and certified genetic counselor.
I think at this point there's a lot of active research going on in the genetics of autism, but we really don't have a lot of information yet about what genes are involved, and it's becoming complex where we think actually there's probably different genes in different cases. So the short answer is no, there's no genetic test to rule out autism yet prenatally. There is a test that's being done more and more routinely, a screening test for Fragile X syndrome. It's a blood test to see if a woman's a carrier for Fragile X syndrome, which is one potential cause of autism, and that is one cause of autism that can be ruled out prenatally.
Oh, that's good. That's very good information. Other questions? We have a question over here.
Thank you very much. My name's Kristen Magnaca, and I was the older maternal mother way back when. And my only option was the amnio, and I declined that because of the years of infertility treatments to get to the point of being 39 and pregnant.
Mm-hmm.
So my question is to you, is this a cost to the patient? Why isn't this standard being offered to women in what was my case of being 39 and pregnant? I chose, ultrasound to determine, some of the factors for Down syndrome. But so that's my question is, how do you integrate that into your practice, and is insurance covering this test?
So the question is, at the time that you were pregnant, this wasn't available. And so now what is available for women? Is it covered by insurance plans? And and how does a woman access this? Does she need to ask for it? Is her provider offering it to her? Let me start with Dr. Wolfberg, and then I'm going to have Jennifer weigh in.
So I will just share a little anecdote. I have a good friend who I went to medical school with, and his wife was pregnant with their second recently. And she had been a slightly older mother with her first baby and had an invasive test. And we had this discussion about what to do with the second pregnancy. And she opted for the Harmony test because she felt that the information had finally risen to the level that she was comfortable with, and she didn't have to take the risk. So I hear you, and we're glad that that's available now. In terms of coverage, the way the test is ordered is through a woman's doctor. She talks to her doctor, and the test can be ordered. And one of the things that we're most proud of at Ariosa is how we've made the Harmony test accessible, because it is, in many cases, covered by insurance. And particularly for patients who are older, we find that coverage is really excellent. But for those women who, after speaking with their insurance company, find out that at this point in time it's not a covered service, the Harmony test is the least expensive of the options that are out there. And we're really proud of that because we're confident of the results we provide. We're proud of the technology. We're proud of this service that we can bring to pregnant women in the United States and abroad. And we wanted to make it accessible at a price that was affordable. And so that's great information.
Great. Do you have anything to add, Jennifer?
I would just say, in terms of access to care and who is offering this test at this point, just in the year that I've been at Ariosa, we've seen really rapid adoption of this technology. It's really kind of unprecedented in the field of prenatal diagnosis. I think it took 10 years to have professional societies come out in favor of a nuchal translucency ultrasound to screen pregnancies for aneuploidy. And so I think with non-invasive prenatal testing like the Harmony test, within a year of the launch of the first test, the American College of Obstetrics and Gynecologists came out in favor of this testing, that it should be offered for women at high risk, at least, for chromosomal conditions. So we've been seeing obstetricians and maternal fetal medicine specialists, even fertility specialists, genetic counselors across the country just adopting this very quickly. So if the patient's physician doesn't currently offer it, it's certainly something that she could ask about. And is out there.
For me in Silicon Valley, where there's all kinds of different technologic and innovative changes, we've adopted it. And most people have. What's the experience in Atlanta?
Well, in Atlanta, in my patient population, especially for women who are over the age of 35, it's fairly routinely covered. But you're right, under 35, it's not always covered. But as Dr. Wolfberg pointed out, it is very economical. So a lot of patients have the ability to either pay for it out of pocket, and they try and make it more affordable. Yeah.
Mm-hmm. Thank you. Great question. What other questions are there? While you're thinking about your question, I have a question, and I think this is important. We're talking about the Harmony prenatal test. This is a screening test, and yet there's also diagnostic tests. So, Dr. Fairbrother, would you like to talk about the difference between a screening test and a diagnostic test?
I think the difference that we talk about is screening tests usually give you a ratio, a risk ratio. Jen's watching me closely, making sure I say it right. A screening test gives you a risk ratio, whereas a diagnostic test is going to be a definitive yes or no. And I think the the way that we have the Harmony test. I mean, when you have a 1 in 10,000 chance with that really takes that risk ratio about as close as you can to definitive without being definitive. And that's the difference between a screening test versus a diagnostic test.
That's great.
I think that's absolutely right, Genevieve. And we as physicians are incredibly conservative, and we don't like risk at all. And so we do recommend that a positive test or a high-risk test from a non-invasive prenatal test be confirmed with an invasive test like an amniocentesis or a chorionic villus sampling. And I've been in this situation. When you go to counsel the patient who has a high-risk test and you're talking about the invasive procedure, you're counseling with a really high level of confidence in that result and the reliability of that test. And it changes the dynamic. It changes that clinical encounter, and it just makes an enormous difference.
When this test is reported, I'd like you to talk a little bit about how it's reported so that you have that confidence that is this, oh, well, gosh, you might be at higher risk, or really you are at very, very, very high risk. So tell us a little bit about that, how it's reported.
Right, and that's exactly what I was going to say in response to your comments, is that the older screening tests that we used to have would report out risks anywhere from 1 in 10,000 to 1 in 2 chance for a chromosomal condition, and anywhere in between. And I think it would sometimes be difficult for patients to figure out where their line was, where that risk was high enough for them to want to take some further action versus low enough that they felt comfortable and didn't really need to do anything else. And that was a real counseling challenge with those kind of intermediate risk scores. But with the Harmony test, we report out risks at either 1 in 10,000 risk or greater than 99% risk for the chromosome condition of interest. So, it's like we said, it's a much more accurate screening test. It is still a screening test. Biology is messy. There's an exception to every rule. So we do recommend high-risk results being confirmed by a more diagnostic test. But the majority of results really fall at these risk extremes, and it makes counseling that much easier to decide what to do next when you're facing a 99% risk or a 1 in 10,000 risk.
So it's actually reported that way. It's reported as a 99% likelihood or risk that there would be this genetic condition, or less than
1 in 10,000.
0.1% risk, right? Less than 0.1% risk.
Right.
That
0.01%.
0.01. So that's really much easier as a healthcare provider when you're talking to a woman.
When you talk about that 50, when you know in your mind from the other screening tests that there's a 50 in 1,000 false positive rate, and maybe there was a 3 in 1,000 risk versus a 3 in 1,000 risk and a 1 in 1,000 false positive rate, that's, when you're talking to those 4 people, then that's why you are going to direct them more to the diagnostic. You're going to be more invested in going for a diagnostic test, which is what I think you were talking about. Where if it's 53 people and 50 of those 53 people are going to be false positive.
Right.
I'll give you an example. It comes out of my practice.
Yeah.
I was scheduled to do 2 CVS procedures one morning, not too long ago. And the first patient came in, and the indication for the procedure was a positive Harmony test, a high-risk Harmony test. And I was able to counsel that patient that based on the result of the Harmony test, I was really worried. I was highly, highly concerned that her fetus was affected with Down syndrome. And she understood that and came into that invasive procedure, which did diagnose Down syndrome, with a level of understanding. We were all on the same page. The second patient that came in was a patient whose doctor had referred her for another CVS because she was over 35 and she had had no prior testing. And I said, I know you want certainty, but I can give you near certainty with a Harmony test. Why don't you have that, and you'll avoid the procedure and avoid the risk. So I didn't do the second CVS, and she went and had an NIPT.
Wow.
And it was low risk.
And it was low risk.
Yeah.
Yeah.
So she could have lost a healthy pregnancy from having a CVS. I mean, we don't like to talk about that. We don't like to talk about loss of a healthy pregnancy from an invasive test, but that's a reality. We say 1 in 200 or 1 in 300. We met someone
Well, that's
who
what you
that
said. She
happened to.
declined. She declined.
I can talk to you about that. So I'm a little bit on the nutty crunchy side, and my doctor was borderline nutty crunchy. And he, before we were really going forward with the amnio, which I did not want to do with every part of myself, he came in right before, you know, this decision and told me his friend, who was a OBGYN, was pregnant. And he just started tearing up because she went for the amnio within the same time frame that I was, same maternal age, and she was miscarrying. And so for me, I knew no matter what baby God sent me, I was keeping that baby. But the part that goes near and dear to my heart is the clientele that I work with are all women trying to get pregnant.
Right.
So for years and years, they have been under huge emotional stress to achieve pregnancy, like I was, and then you get them in the room to hear you have to make another decision that you could lose this pregnancy to have information that, depending on your scale, is that you want that information. So the fact that you're saying that you can have this blood test, even if you have to pay for that blood test to get the information from this very, you know, otherwise invasive test, is a no-brainer to me. You know, it's a heartbreaking and a terrible position to put a woman who's 10 weeks pregnant in. So
yeah, it really has, this non-invasive prenatal genetic testing has changed prenatal care. It's completely changed how we care for patients. Now, before we talk amongst ourselves, what other questions do you have? Are there other questions from the audience?
I'm sorry, I have
you have a
something
question?
else to add to Kristen's.
Please.
My name is Fran Meadows, and I too also went through infertility. I also experienced a late pregnancy loss, and when I did get pregnant again, they automatically said, because of my past experiences, they wanted me to have an amnio, and I too also refused. And that was my choice, because I felt at this time I was pregnant again, and this child was going to be loved regardless. Now, are there any other things that you could do to counsel people with past losses or miscarriages, you know, to tell them more about this testing? Because I'm sure they would opt for non-invasive testing versus amnios.
Well, this is a great question, and I think that's what we're really trying to do, is get the word out. Get the word out about non-invasive prenatal testing so that women and their partners and anyone who's trying to have the family of their dreams knows that there are non-invasive tests that have absolutely no risk to the pregnancy, but we're getting highly accurate results with low false positives. Is there anything that anyone would like to add to that?
I think it would, I mean, the first thing I would do is I would send you to a genetic counselor to find out if your first loss was something that was repeatable, or was it something that happened just with that pregnancy. And if it happened, and if it was what would be considered isolated, then I would absolutely offer you the Harmony test. If it was something that there may be repeatable reasons, then that we'd find that out from the geneticist, and see if you would benefit from more invasive testing, or something that Harmony couldn't cover. But Harmony is really for the individual pregnancy, for those non-repeatable conditions like Down syndrome, trisomy 13, trisomy 18. So it's an individual. It would be an individual call. But I mean, you're absolutely right. You've climbed the mountain. You felt like this was your last chance. I totally get that, and I think doing those non-invasive tests is. I see this as becoming the standard of care in hopefully very short time.
I just feel that I did not know the option. Like, there were no options given to me other than the amnio, and it was an isolated incident with my loss. There was no genetic, I guess there was testing done after. But there was nothing, that they determined from it. It was pure accident, unfortunately.
So sorry.
So, thank you. But so I mean, I think that these options should be available to other women that, I mean, especially those that are going through fertility treatments where they get to that pregnancy and they feel, anything they do is going to, be more risky to them because they've been through, so much.
We agree, right?
Yeah, we totally agree. Question here.
I just want to know, how long has Harmony testing existed?
How long has the Harmony prenatal test been commercially available to practicing OBGYN prenatal providers?
I started using it in May of 2012, and I think we were
one of the first.
One of the first practices that used it, and for a very short period of time, we did parallel testing with the second best screening test, and then we've pretty much dropped that. We still do the ultrasound at 12 weeks to look at the nuchal translucency, but we don't do the associated blood work because of that false positive rate.
One of the things that I was really impressed with, and what I'm hearing in your question is, so it's been around for over a year, just over a year, but what do we base this on? We're actually basing this test on data that's derived from real women. This is not just some idea in a lab. This has been tested in real women. How many women?
Right. We actually did a study with Dr. Fairbrother.
I did a study for 300
patients.
But I think Harmony's done a study of, like, is it 13,000 or 20,000 patients now?
So I think that that's one of the factors that differentiates Harmony from the other non-invasive prenatal tests, is that in contrast to some of the other tests, Harmony has been tested in thousands of women. 30,000 women have been in studies, have been in research studies that have been published in the peer-reviewed literature by investigators who have nothing to do with the company. And that kind of experience in a real-world setting, in patients who are high risk, in patients who are low risk, gives me as a clinician the confidence to trust the results. And I think that that's pretty unique. I just wanted to go back to the comment about your loss, and again, I'm really sorry about that experience. It's a really unique one, and it's so difficult, and I'm sorry about that. But you know, the workup after a loss is important and specific, and it does look for some things that Harmony and the other non-invasive prenatal tests do not test for, and so. The thing about the Harmony and the non-invasive prenatal tests is that they test for the chromosomal abnormalities that are most common, that represent 85 or 90% of those that pregnant women should worry about. There are these rare genetic conditions that require invasive testing and will continue to be tested using that technology. And that's the importance, I think that sort of speaks to the importance of an OBGYN or a maternal fetal medicine doctor, and particularly a genetic counselor, and the conversations you can have with those providers so that you determine whether you fit into that very small group of 3 or 4 or 5% of patients who are at risk for a condition that's not covered by this test, or whether you are like the overwhelming majority of pregnant women in a category that would get great information from the Harmony test.
That's a good point.
While Harmony is a fantastic new option for many pregnant women, I think the choice really is an individual one, because some women have been through very unique experiences and have particular concerns. And I think as humans, our experiences shape how we think about things, and you know, the choice of these different genetic testing options is really a very personal one. I think that's why it's important to find a doctor that you can work with and a genetic counselor who will listen to your individual story and find what's right for you. There's no one right answer for everyone. So I think the Harmony test is a great new option that we can offer to pregnant women, but those conversations still need to be had with your healthcare providers, and to find someone who will make that individualized decision with you is very important.
You're so right about that. Are there any other questions?
So is Harmony Prenatal available at every OBGYN? And if it's not, then what do women do? And also, you said 5%? There's 5% of genetic conditions are not able to be screened by Harmony Prenatal. I think you made that point. And what are they?
So let's talk about availability. So this test is available across the country and worldwide.
Yes, and maybe not in every obstetrician's office as of yet. I think most maternal fetal medicine specialty offices now have a non-invasive prenatal testing option, but certainly it's something that you could ask your obstetrician for and is widely available throughout the U.S.
And speaking of sort of accessibility, one of the relationships that Ariosa has, maker of the Harmony test has, is with a company that has 1,900 lab draw sites around the United States. And so if your particular midwife or obstetrician doesn't have the experience of using Harmony yet, it's very easy for them to order the test and have it done down the street, if not at in the first floor of the same building. So it's widely available.
And when we think about genetic conditions, the vast majority of genetic conditions that affect pregnancies are Down syndrome, trisomy, which is trisomy 21, trisomy 18, trisomy 13, and then there's others. So when you think about the whole group that we can currently screen for, does Harmony test for the vast majority of those?
Well, I think there's two different types of genetic conditions. There's genetic conditions which are inherited, and then there's chromosomal conditions. So I think the detailed family history really gets more into those genetic conditions that are inherited, those 20,000 genes, and we do what we can for those types of conditions. There's a lot we can't test for there. But then there's chromosomal conditions which are more random and are more age-related. And Harmony test really focuses in on those more random conditions that are not really based on family history, such as the trisomies and now the sex chromosome conditions as well. And we have 23 pairs of chromosomes, and there can be variations on any of those chromosomes. It's just we find that usually if there is an issue with the chromosomes in pregnancy, it's with one of the 5 that are addressed by this test.
So the vast majority of women who are coming to practices that you're seeing, Dr. Fairbrother, they're going to be affected by this group of common conditions.
I think these are the ones that are most likely to affect a pregnancy. And they're the ones that we're most concerned about.
And they're the ones that everyone really needs to consider, as opposed to family
someone
history.
who's a generalist, and in my practice, we probably deliver about 2,000 babies a year. The chance we're going to see something outside of trisomy 21, 18, and 13 is extremely remote. It's the ones where they have the family history, where there's the genetic abnormality in the parent that gets transmitted to the child. And then we are aware of it for the ensuing pregnancies. It is, what we would call de novo mutations are really very unusual, and you're going to see them like once every several years, and those ones are not picked up by the Harmony test. But the ones that you are going to see much more, the 1 in 300s, up to the trisomy 13 is 1 in 10,000. So when you see those are what's being tested.
Nurse Barb, I think we have time for one final question. So did I miss? I thought I may have saw one more hand.
Is there another question? I actually have a question. What about families? Is there anyone who shouldn't have this test? Is there anyone you can think of who shouldn't be having this test or shouldn't be offered this option? What about families who are using egg or sperm donation? Is this a good option for them?
Absolutely. Absolutely.
And why is that?
It actually looks at the fetal DNA in maternal circulation. So whether it's your own genetic material being contributed to that pregnancy or not, we're actually looking at the fetal DNA and evaluating that in each pregnancy. So egg and sperm donation should not affect the Harmony prenatal test.
Twins, you can do twins.
Oh, and
you
you
can do twins as well, with self or non-self egg donor pregnancies, surrogate pregnancies, all eligible.
So what I'm hearing is that this is not a brand new test. This has been around.
It looks like if you're pregnant.
If you're pregnant, this is a good
right,
test
you have to be
for
pregnant,
you.
right?
Yeah, you have to be pregnant. We decided.
You have to be pregnant. So if you're not
Otherwise
pregnant,
it won't work.
This has been an amazing panel discussion. I know that we've covered a lot of ground here, and I'd really like to thank all of you for being with us today. I'd also like to especially thank our online audience for joining. You can share your experiences on Twitter or Facebook with the hashtag FP13NY. You can also view all of the programs on fertilityplanet.com. You can do this free all weekend and then on demand starting tomorrow, September 16th. I'd like to thank all of the partners and our incredibly brilliant and informative panel of experts for sharing their experience and their wisdom today. I'd also like to thank the sponsor of our session, Ariosa Diagnostics, for supporting this conversation. I'm encouraging all of you to visit us at the Harmony booth after this session and on any of your breaks. Each of the panelists will be available for private conversations, one-on-one, right outside. Will be available for the next 15 minutes. And now I'd like to close this session on non-invasive prenatal genetic testing, and we'd like to see you more. You can also go to ariosadiagnostics.com for more information. So I want to thank all of you, and thank you very, very much.
Thank you, Barb.
Thanks.
Thanks.